I want to thank everyone for joining us today. Good afternoon. Today is the latest in the Philips AntMini webinar series. My name is Walt Schoenborn, Director of Media here at antmini.com, and we are excited to share with you the second installment of the Philips 2021 webinar series on the path to precision diagnosis. Today's presentation is part 2 in the Philips series and is entitled Strengthening Clinical Confidence in Multiple Sclerosis. And just as an aside, this is something that hits very close to home for me, and I really appreciate it. And I want to give a special thank you to Philips for the dedication to the treatment of this disease. It's very personal to me, and I appreciate it. I'm very much looking forward to this presentation. It's going to be a great session with lots of content, so I'll try to keep my introduction short to allow plenty of time for questions at the end. A reminder to please submit your questions in the Q&A footer at the bottom of your Zoom screen, and we'll be selecting questions to present to our panelists during that portion of the presentation. There will also be a follow-up email to all registrants with a link to today's recording to be viewed on demand, as well as an email address to submit any additional questions after the session has ended. Philips has transformed into a company that is fully dedicated to improve the lives of people through sustainable innovation in healthcare and bringing solutions that allow a clear pathway to precision medicine. Today's webinar will be focused completely on multiple sclerosis, which is, as you all know, a devastating neurological disease that affects around 2.5 million around the globe and has a large effect on quality of life from an early age. The care for people with MS has improved substantially over the past decades with the introduction of disease-modifying medications and improved imaging techniques, but there's also still a lot of unknown about the etiology of the disease. Philips is investigating to further enhance the clinical workflow related to MS and other neurological diseases, and is supporting research to enhance clinical capabilities for diagnosis and follow-up on the disease process related to imaging, image processing, and interpretation and cognitive assessment. We're delighted to welcome 2 great presenters today as we have a very special 2 presentation session. Firstly, let me introduce Dr. Anthony Traboulsee. Dr. Traboulsee is a professor and research chair of the MS Society of Canada at the University of British Columbia in Vancouver. He is a director of MS, NMO, Clinical and Clinical Trials Research Group at UBC Hospital. His research focuses on clinical trial design, the development of practice guidelines for the use of MRI in the management of MS, establishing advanced MRI imaging outcomes in multiple sclerosis, and the treatment of neuromyelitis optica. Our second speaker today is Nadine Rendiers, Senior Clinical Portfolio Manager in Neurology MRI at Philips. Nadine is a graduate of Maastricht University, where she obtained a master's degree in psychology and additionally in health policy. During her career, she had different roles within the university before moving towards a more business-focused role. Before joining Philips, Nadine worked several years as a business developer, bridging the gap between science and business with a specific focus on imaging and ultra-high field imaging in particular. Since January 2019, she is working for Philips, where she is responsible for the neurology portfolio and the roadmap of future innovations. Both presentations will be playing in tandem, after which we will open the panel to live Q&A from the audience. Please type your questions in the Q&A section at the bottom of your screen, and we will select relevant questions at random to present to the panelists as time permits. As a reminder, there will also be a follow-up email to all registrants with a link to today's recording to be viewed on demand, as well as an email address to submit any additional questions after the session has ended. Look out for this email in the next few days after the event has concluded. Without further ado, I am pleased to present Dr. Traboulsee's presentation, immediately followed by Nadine's presentation. Please allow me a moment to share my screen and enjoy the content.
Hi, I'm Tony Traboulsee, neurologist at the University of British Columbia and expert in multiple sclerosis and the aspects of imaging associated with that. I want to give you an overview of where we are with using MRI in clinical practice and some of the areas we're working in terms of research and developing new MRI techniques that might be used in clinical practice in the future. But currently, we're really using MRI to monitor and detect old and new inflammation, or the classic plaques of multiple sclerosis, and that's been quite useful for making an early diagnosis and monitoring treatment response in patients with MS. And what I hope to convince you is that we can optimize our clinical use of MRI by using standardized protocols that could open the door for future quantitative measures, which are quite an exciting area to better inform us of the health of our MS patients. And then finally, looking at some of these new sequences or advanced imaging sequences that are mostly used by people in the research field, but really have a lot of promise to being applied in clinical practice as time goes on. These are some of my disclosures, most of course are related to the pharmaceutical industry in terms of different drug studies I've been involved with, as well as advisory boards. So perhaps the main focus in clinical practice has been the role of MRI in detecting focal inflammation. So let's explore that a little bit more. MRI has been around for, gosh, 40 years, and in neurology, it's had perhaps its biggest early impact in multiple sclerosis. Finally, having a tool that could detect the classic plaques or lesions of MS, and that's seen in the picture on the left. It's a very old image from our first clinical and research scanner. It was a 0.15 Tesla, one of the first scanners in North America. And it was quite revolutionary, although it took about 30 minutes just to get that one slice. It was quite a slow process. And then over time, the next decade or two, a lot was learned from using MRI about the pathology and evolution of lesions in multiple sclerosis and how lesions could develop in the absence of new symptoms. And it really has led us to where we are today and how we use MRI in clinical practice as well as in drug development or clinical trials. So for example, what you're seeing on the right is a single patient, the same slice imaged consecutively over about 9 months. And so a lot of the natural history studies, particularly patients who weren't on any treatment, would show us that most patients would develop new lesions in the brain in the absence of symptoms. And it was quite common. For example, for every clinical attack a patient might have, we could see up to 10 new MRI lesions in that same time frame. So it became a very sensitive tool for detecting clinically silent disease activity, which has a lot of biological and pathological relevance. What are we seeing with the MRI? What are those lesions? And so here's just a cartoon illustrating the mechanisms of MS. The blue cells represent lymphocytes trafficking through the bloodstream. And the idea, of course, is that MS is an autoimmune disease where there's a group of lymphocytes become autoreactive, and they're circulating. If they become activated, they will stick to the blood-brain barrier and traffic into the CNS and create this inflammatory cascade by attracting other immune cells such as macrophages to cause demyelination and the inflammation we see on MRI. And this is what we see on MRI. You have paired images here. That's a kind of a blow up of a new lesion developing. So the pre-lesion tissue on the proton density on the left and the T1 post contrast on the right. No lesion is seen in that white matter. However, as a lesion is developing, it can be quite large on the T2 weighted proton density image, and it is often associated with a temporary breakdown of the blood-brain barrier where gadolinium or some kind of contrast agent will leak into the tissue, reflecting that injury to the blood-brain barrier. That is a self-limiting process. The autoimmunity process will turn itself off, and the lesion will start shrinking down. The blood-brain barrier will heal, and so we won't see any more contrast going into the lesion. But there will almost always be residual T2 or bright lesion left behind, and those lesions will accumulate over time. So we often use the T2 lesion as a chronic marker of ongoing inflammation or cumulative inflammation, and we use the T1 contrast study for the brand new or acute or temporary inflammation that's going on. This evolution of knowledge around lesion development and history is really what's paved the way to allow us to do an earlier diagnosis using MRI as a supportive feature, not a diagnostic, but a supportive feature. The MRI criteria that's gone through many evolutions from 2010 to 2017 is valid when applied to a very specific population with symptoms consistent with MS, optic neuritis, transverse myelitis, those sorts of symptoms. And so we can use certain features on the MRI, certain lesion types and locations to support the concept of a disease that has inflammation disseminated in space or different locations in the central nervous system. But perhaps where the real power of the diagnostic criteria comes from is that dissemination in time criteria, using MRI to pick up new biological disease activity well before a patient has an attack. And here's an example, 3 large clinical trials, just to give you a sense of the natural history. For example, at the time of the very first scan, almost between 30 and 50% of patients might have an enhancing lesion on that very first scan, and that would represent acute inflammation in the background of chronic inflammation, and those patients would actually meet the new diagnostic criteria for MS. And for the patients that don't, over time, within 12 months, 3/4 of them would have evidence of new lesions showing up, meeting the dissemination time criteria. And if you compare that to the proportion of patients who would have clinical attacks, you're really only seeing maybe 1/4 of patients or 1/3 of patients having a second attack. And this is a very high risk group. And so you can really see the power of MRI, looking for that evidence of dissemination in time that can allow for an earlier diagnosis in the majority of patients who have multiple sclerosis, especially the relapsing remitting form of MS, which is the most common form and the treatable form. The other area, of course, where MRI has been really powerful is in clinical trials, identifying the efficacy and the appropriate dose of all the medications we now use for the treatment of relapsing forms of MS. And the nice thing with MRI is you can use a much smaller sample size or population to look for the dose effect before confirming that in a larger phase 3 trial. So it creates a great cost savings for drug development, which is of course important because it also speeds up the time to getting these drugs to patients. So this still is one of the standards for developing new therapies for relapsing forms of MS. And then, of course, all of this work and research and clinical trials have been translated into clinical practice with a lot of good data supporting the role of using MRI to monitor patients in terms of what to look for and how frequently to look for it. And here's just another example of a nice high quality 3D acquisition showing very small lesions showing up in the medulla on the T2, post-contrast flare and the post-contrast T1. So nice to have that high quality where we know if there's breakthrough disease activity going on. And sometimes that will influence our treatment decisions for individual patients in addition to other factors. So then, one of the hopes is, can we get more information out of these MRIs? And there's kind of a couple of aspects to that. One, of course, you're going to get more information, more reliable information by using a standardized protocol. MS is a chronic disease. We're often repeating the imaging studies for many patients on an annual basis, especially early in their disease course or if we're switching treatments. And so if we are seeing changes on the MRI, we want to be confident those are true biological changes and not just changes because we went from a 3 millimeter slice thickness to a 6 millimeter slice thickness and we're seeing some volume averaging. We're not sure how to interpret that. And so working for over a decade with various groups, and we've been able to come up with some what we hope are practical clinical guidelines and protocols done in a reasonable time on any scanner to give patients and clinicians good quality images that they can compare over time. And we're really pleased with the last version of these guidelines to work with several of the manufacturers as well to hopefully get some of these protocols incorporated into the scanners. And this is the standardized protocol. I wanted to highlight two colleagues. David Lee is a radiologist I've worked with for a couple of decades, and Laura Barlow is our technologist on our 3T scanner. And these are the core sequences we recommend. Focusing a lot on these 3D acquisitions. They're beautiful, they're reproducible. You can reslice them how you need to get the good orientation, a consistent orientation over time. So, and they're very practical on the majority of scanners. Even older scanners can usually acquire this. So I won't go into extensive details about these sequences, but just to say, really encourage people to use a standardized protocol so that they can compare studies over time for their patients, especially if patients are moving around. It'd be nice to have compare apples to apples, so to speak. So here's just an example of the application and the time it takes on our new Philips 3T scanner at our center. Only took a little over 18 minutes to get the full package. And the core package includes a 3D flare, a 3D T2, and a 3D T1. The 3D T1s are nice for doing future volumetric measures, in other words, looking for brain atrophy measures. And we also like getting a diffusion weighted image. We don't use diffusion a lot for monitoring regular MS. It's nice in the diagnostic workup. It's also nice in patients on medications that might put them at risk for an infection called PML. And so so we've included that as well. And so we've also worked with several groups in terms of developing what we hope are rational recommendations or guidelines for how often to do MRIs, when to use contrast. There's been different discussions about potential accumulation of contrast. Unfortunately, we're not seeing any neurotoxicity with that, of course, and with the newer contrast agents, that seems less likely to occur. But nonetheless, we recommend judicious use of contrast, and certainly at the diagnostic workup, there's high value in using contrast, one, to establish dissemination in time and space in the high-risk MS patient, but also to rule out alternate diagnosis, so incredibly invaluable. And then there's certain times where a spinal cord MRI, especially the cervical cord, can really add value in that diagnostic workup. In terms of follow-up, using a standardized protocol, of course, depending on the scenario the patient needs, roughly every 6 to 24 months for relapsing MS patients. And it really depends on how stable they are, how active their disease was at the beginning. Do you need to get a new baseline after switching treatment? So these are all really spelled out in previous publications, but also a new publication hopefully coming out this year. That's more of an international guideline that combines the North American guidelines with the European guidelines. Well, where we'd like to see this go even further is getting more quantitative data. And there's several different groups out there, commercial groups that can provide quantitative data. And of course, the whole idea of that is to get more reliable information with less work on us as readers. And it really has a lot of promise, a lot of usefulness. However, the big thing, of course, is having good quality imaging data going into that. And so if there is a lot of inconsistencies in the studies that are being analyzed, you're going to get spurious results that may not be reliable to make treatment decisions on. And so whether or not you're using quantitative outcomes today, chances are in the future you will be, at least wanting access to those. So by, again, collecting MRIs by standardized protocol will put you in a strong position to take advantage of that technology. This is just an example of some other tricks and tweaks we've been working on, is trying to improve the sensitivity of standard imaging to pick up lesions, a technique called FLAIR squared, where you combine after you acquire the data, even on the scanner, you can combine the T2 and the FLAIR, and it really makes lesions, especially juxtacortical and cortical lesions, really jump out. It's quite a nice, simple approach. And some other areas that are developing in clinical practice, there's a lot of interest in the central vein sign. And the whole idea is MRI is exquisitely sensitive for picking up abnormalities, but not necessarily specific to the disease process that created those abnormalities. The central vein sign takes advantage of the idea that MS lesions develop around veins, and using techniques such as susceptibility weighted imaging, which is most scanners are doing nowadays, and combining it, for example, with the FLAIR, you can create a map of veins associated with lesions to determine if there's an if most lesions have this central vein, that might favor MS as opposed to vasculitis or non-specific white matter lesions that are common in the elderly. This, I think, is still a work in progress before it's routinely used in clinical practice, because it can be a lot of work if there's a lot of lesions, and we want to stay friends with our radiology colleagues. And then I guess where I would see things going further is, again, with having good quality standardized imaging, having tools on the workstations that can take advantage of this longitudinal data sets for individual patients, and rather than trying to upload information to the web and then download the results hours or days later, getting those results, these longitudinal quantitative changes in real time, could really enhance the radiologist's experience and the timeliness of reports in terms of how MS patients are doing, beyond just counting lesions, which is taking more and more advantage of the MRI data that's been collected. So now to switch gears to, where can we go? If we can get quantitative imaging standardized protocol, what else do we need to know about the MS brain that we can tease out of MRI? Well, there's more going on in MS than meets the eye. So we often think of MS as multiple scars or all the T2 lesions, yet patients can still degenerate or progress, get worse over time in the absence of developing new lesions. And what is very common in all stages and phenotypes of MS is global atrophy, brain atrophy, spinal cord atrophy. And you can see, as this video cycles through a few times, this is a patient with an MRI once a year. And you can see the dilation of the ventricles, the deepening of the cell side. And that's a really important process in multiple sclerosis, that the pathophysiology of what's driving that is not fully known. And just to give a sense, sadly, all of our brains are having some atrophy going on, but the rates in patients with MS is about 10 times faster or greater annual rate of atrophy than in the otherwise healthy population. And so it's a very important aspect of the disease that is hopefully is treatable with some of the treatments we have, and more treatments in the future. But to use this knowledge in clinical practice, we want to be able to have those valid quantitative measures. But in research, what we're trying to do is understand what's the mechanism of that atrophy. How is MS damaging the brain globally? And so there's multiple areas called advanced imaging, magnetization transfer imaging, diffusion weighted imaging, and area we're working with called myelin imaging. The whole idea is imaging is picking up water molecules. So for example, MTR is picking up the impact of hydrogen atoms in lipid and how it transfers to water. There's water within the bilayers between myelin, and that's what our technique is looking at, is this trapped water. It doesn't typically show up on a standard MRI. You have to look for this with a different specialized sequence. And then diffusion looks at water within the cells and around the cells. So it tends to be a little less specific to the pathology we're interested in, which is the myelin. And so I'm going to show you how we've applied this in our research program. Here's some lovely work done by Shannon Colin with one type of myelin imaging. And here you can see two patients, one with a very low level of disability on the left, one with a high clinical level of disability on the right. Their FLAIR image looks pretty similar. You can see the lesions, but not a lot of lesions. Yet there's this big difference at disability level. So she was able to create these myelin water volume fraction maps and color code them relative to healthy controls. And so areas that are dark are typically lesions and represent severe demyelination. Areas that are in between the kind of the dark purple, blue to purple, are areas that are diffusely damaged. So they look normal on the conventional MRI, yet they have a diffuse loss of myelin throughout the tissue. And then the brighter color, of course, is more normal myelin. So you can see more clearly visually between these two patients that the person on the right with the greater degree of disability has a greater global loss of myelin, which could in part explain her disability. And what's really neat with some of the work Shannon's been doing is trying to convert this not only into use in clinical trials, we've had some great success with that, but also into individualized patient monitoring. And here's an example of looking at two patients with change over time. You can see what's represented on the left is areas that are colored were areas that were abnormal to begin with, and then became more abnormal over time. Or red areas or became improved over time, or green areas are relatively stable over time, where the yellow areas. And so the patient on the left over 2 years didn't get better, but tended to get worse in the normal appearing white matter. Patient on the right tended to get better in terms of the brain health with this myelin imaging. So a really exciting tool that we can use on a population level and hopefully translate it into patient care in the future. We've also looked at this type of technique and seeing the relationship with cognition, work by Shauna Abel, our most recent graduate. So what we looked at was a simple processing speed test called the SDMT. And on the very bottom panel on the left, you can see a person who had a normal cognitive testing with that tool, and their myelin profile is this nice big tight hump. And then the person at the very top who did very poorly on that cognitive test, very slow processing speed, a lot of mistakes, and their myelin is not, their myelin profile is very poor. It's spread out, a lot of low values, and so overall diminished myelin. So it can relate, these new techniques can relate well to various aspects of brain health or brain injury. And how we're taking this further is creating these normative atlases so that in the future, individual patients could be mapped to a normal atlas to get a sense of how far do they deviate or match up with the general population. Great work by Adam Dvorak, our current PhD student. And here on the left, you can see myelin imaging of the brain, two different types of myelin imaging. On the right, myelin imaging of the spinal cord. Other areas that we've been collaborating with is with, again, great tools you can do with MRI, functional MRI with Martin McEwen. And the whole idea is looking at resting state fMRI, where patients are just lying in the scanner and not thinking of anything, which I would find very hard to do. And you can just see different parts of the brain in the resting state or the default mode have some activation or increased blood flow, which is what this is picking up. And MS patients might have a different pattern. And not only can we look at those different patterns, we can see how those patterns interrelate to different regions of the brain. But we looked at about 40 different regions of the brain, trying to see, does area 1 match up with area 2 in terms of activity or decreased activity? And you can get a certain pattern of this connectivity between areas of the brain by using analysis of resting state functional MRI data. And then in MS patients, you might see a very different pattern that represents compensation. And so a brain that has minimal structural damage or even moderate structural damage might be able to compensate for that damage and perform well. And we can pick up that performance using techniques such as functional MRI. So again, I can't cover all the really neat areas that other groups are doing with advanced imaging that might in the future translate to clinical care. But what I really wanted to highlight was, currently how we're using MRI is quite limited. We're really focused on lesions to make an earlier diagnosis of MS, to monitor treatment. And we can improve that by using standardized imaging protocols. And that will also open the door to allow us to get more quantitative measures, not just of lesions over time, but of whole brain atrophy over time that might influence how we manage our patients. But I think where the future is going, in addition to that, is looking beyond the lesions to use some advanced MRI techniques that can be translated into clinical practice, that can be reproducible, that can be done in a reasonable time frame and analyzed on hopefully at the workstation or easily. That can give us a better sense of neuroprotection, repair, remyelination, and that might really enhance how we're treating MS patients and other neurologic conditions in the future. I'd like to, of course, acknowledge an enormous number of people who do all the work and allow me the chance to present some of the work we're doing here at UBC at our 3T Center. Thank you.
Well, thank you very much, Dr. Traboulsee, for this very excellent and interesting presentation. And it clearly demonstrates that the major impact imaging has on diagnosing MS patients over the years, but also the many areas which are still there to further explore. My name is Nadine Reinders, and I'm a clinical portfolio manager within Philips. And today I will show you some of the innovative solutions in the field of MS diagnosing and follow-up, which are there to design to improve the lives of both patients and professionals along the MS care pathway. As Dr. Traboulsee already highlighted in his presentation earlier, an important clinical tool for the diagnosis of MS and follow-up, but also monitoring of treatment response is MR. There are disease-specific challenges radiologists and neurologists are facing when delivering a fast diagnosis with confidence and treating MS patients. There's an important factor here, and that's actually time. Scanning MS patients requires longer acquisition times due to the 3D component, which is part of the MS protocol. But also the setup time for these patients can take longer. Also delivering a diagnosis with full confidence. One of the key challenges here is actually to come to a more and improved differential diagnosis for MS patients, and therefore really to reduce the 20% misdiagnosis. This has mainly to do with the fact that white matter lesions, which are the main biomarker on imaging, are not specific to MS. There's also a need to improve the longitudinal follow-up of disease progression and therapy effectiveness. It's difficult to view and compare these often subtle changes in images with different intensity scaling, orientation, and location, but also longitudinal tracking of the cognitive status of a patient in a fast and quantitative manner. Finally, we also see that in the comfort area, there's a big need, especially if you know that the standard MS protocols take longer than average, and patients have to be scanned for follow-ups sometimes up to a couple of times per year. It's actually good to show you today that within Philips, we have designed solutions that actually fully support these needs. If we look at imaging with products such as CompressSense to shorten the acquisition time, the FLAIR-STAR protocol to enable more information on MS-specific lesions, and MR-LoWi to support longitudinal brain imaging. But also in measuring the cognitive status of patients through easy digital cognitive assessment via the IntelliSpace Cognition platform. Additionally, there are the comfort matrices and smart workflow solutions to improve patient comfort. Now, let us dive a bit deeper into the solution, starting with speeding up the scan times. With CompressSense, we can really bring a breakthrough here in productivity by accelerating the full patient examination. It's actually an acceleration technique, speeding up not only the sequence, but the entire exam. And this really enables an acceleration of MR exams up to 50% here, with virtually the same image quality. It can be applied to all 2D and 3D anatomical contrasts, and actually for all anatomies. And the great thing is that you can also choose to maintain the scan time and therefore increase the resolution up to 40%. CompressSense is actually in particular of benefit for MS imaging, as CompressSense can be used for 3D brain exams. Most sequences are actually 2D, and then we're talking around roughly 80% of the sequences. However, for some neurological conditions, such as MS, you are actually required to scan in all three orientations. The benefit of such a 3D scan is that with this one single scan, you can actually view the image in any direction. But there is a downside, however, and that actually requires longer scan times. Now with CompressSense, we can really make a step forward here and increase the scan time up to 50% and therefore make those 3D examinations much more accessible for clinical use, such as MS. And this is also actually very nicely shown in the presentation of Dr. Traboulsee earlier, where the standardized MS protocols, including 3D imaging, has been scanned with CompressSense. Another advantage is that it also decreases the risk of motion artifacts, which is a common risk when using 3D examinations. And with this, we can also really support our customers in improving MS imaging. And here, this slide actually shows an MS case where the MS protocol has been scanned in combination with CompressSense, allowing for much shorter scan times, but still with equal image quality. As mentioned at the start of this presentation, improving diagnostic confidence and longitudinal follow-up, both in the imaging side as well as cognitive functions, are important needs within MS. And as also shown by Dr. Traboulsee, studies report that most MS lesions are actually centered around a small vein. And the central vein sign here refers to a vein which is visualized inside a white matter lesion on a T2 sequence that appears as a hypointensity relative to the surrounding lesion. The vein appears as a dot or a thin line that is located centrally or running partly or entirely through the lesion. And the central vein sign has actually been proposed as an imaging biomarker of great diagnostic value for distinguishing between MS and MS mimics. Criteria suggest to distinguish MS from non-MS diseases if in at least 40% of the lesions a central vein sign can be seen. And in order to visualize such a central vein sign, you can generate a 3D flare for visualizing the white matter lesions and a 3D multi-shot EPI for visualizing the veins, which are actually both standard available on the Philips systems via scan tools, providing the basis which is needed for co-registration into a flare star, which can currently be done offline by the users. If we then actually look at the specific MS case here on this slide, you can see here a patient with relapsing remitting MS, and you can actually clearly see a white matter lesion on the 3D flare contrast at the left, where the central vein sign can be detected with a 3D MS multi-shot EPI. By offline processing by the customer, they can then actually generate the flare star contrast, enabling the visualization of the veins actually running through the lesion, providing more advanced information on the status of the patient. And here we can also see the difference, because here we're actually looking at a patient which is diagnosed with migraine. And also here we can clearly see the white matter lesions on the 3D flare contrast. But the difference here is that with the 3D multi-shot API, it doesn't show any central vein sign. So also here, it really shows the added value and the benefit of making a better differential diagnosis here. Well, as explained by Dr. Traboulsee, post-image processing tools taking advantage of the longitudinal data sets to assess changes in real time can actually be very valuable in order to monitor treatment response. For example, how advanced visualization can actually help in identify subtle changes between the two images like these ones. Is there actually a disease progression, or is there remission? And to what extent are there differences between these two different time points? The longitudinal brain imaging application applies several algorithms, including bias field correction, rigid co-registration, and intensity scaling before subtracting the current and prior images. And this results in a color-coded map overlaid on top of the anatomical image, which highlights differences between the two time points and helps to visualize very small changes that may have missed otherwise. A few studies have actually been published, providing further insights about this co-registration color-coded functionality. For example, actually this paper here by Dr. Zafs and his colleagues from the University Hospital in Cologne, comparing standard conventional reading to the reading supported by automated color-coded algorithm. And as you actually can see here, with the tool, progressive lesions are marked in red and diminishing lesions are marked in blue. As reported in the paper, the diagnostic accuracy actually increased significantly from 70% to around 90% when reading was supported by the automated approach. And in addition, reading time was actually reduced by 25% using the automated workflow. The longitudinal brain imaging application is available in Philips IntelliSpace Portal post-processing platform. And the application supports many types of MRI data, including FLAIR, as used in this study, but also T2, T1, diffusion, or ADC. The application helps also to compare up to 4 different time points. Regions of interest can be segmented, qualified, and changes can be monitored over time to assess treatment response. The application is used to monitor different conditions beyond MS, such as brain tumors as well. And we also briefly touched upon cognitive assessment. But why is that actually so relevant for MS patients? Well, studies actually show more and more that cognitive impairment is a very early indicator of a disease activity. And actually, in fact, in a 10-year-long study, people with cognitive impairment at baseline had 3 times greatly likelihood of reaching an EDSS score of 4 and were twice as likely to convert to MS than people without cognitive impairment. And cognitive impairment is actually the #1 reason for MS patients not to participate in employment anymore. And also, more than half of the neurologists surveyed by Philips say that they consider adapting the MS medication based on the cognitive status of the patient. Neurologists told us also, however, that patients were impacted by the long waiting times for neuropsychological assessment, and that having more information early in the process could really help to better make decisions. And this was actually one of the primary motivations to create IntelliSpace Cognition. IntelliSpace Cognition, or ISC, was released by Philips in the US in June 2020 and is actually a digital cognitive assessment tool targeted to neurologists. ISC includes a digital battery of well-established neuropsychological tests that cover the different cognitive functions of the brain, with the results being mapped to the domains. And the full IntelliSpace Cognition battery takes around 45 minutes to perform, though it's also possible to perform single tests if preferred. An ISC consists of a patient interface, which is delivered on an iPad Pro, and a cloud-based clinician interface available via any computer or tablet. And being hosted on the Philips secure HIPAA compliant cloud, the results of the assessment can be viewed instantaneously after data collection by the clinician, either on the same iPad Pro or on any desktop with internet connection. And the tests have actually been co-normed for the US demographics and provide highly quantified measures for cognition that can be tracked over time. And this allows for the assessment of effects of disease-modifying treatment on cognitive performance. The individual tests were validated extensively against the paper and pencil versions, with scoring algorithms being highly correlated to the results of human scores. And being listed as an FDA Class II medical device means that for each release, an extensively validated with practicing neurologists for usability, resulting in an easy-to-use product. The application also uses AI and other advanced algorithms such as voice recognition to first automatically score the test, norm the responses, and then map these to cognitive domains. When referring to cognitive assessment in MS, clinicians often think about processing speed, a domain which is often impaired with this disease. And as you have heard from Dr. Traboulsee in his presentation, myelin water imaging is actually strongly correlating to the SDMT performance, a common measure of performing speed. While SDMT is a good measure of processing speed, a digital platform such as IntelliSpace Cognition offers great promise for collecting other new measures to quantify processing speed. Since all mouse clicks and verbal responses are actually recorded, aspects like drawing speed or word recall become options to complement the existing measures. And finally, CTP codes do exist for both the data collection and also the interpretation for neuropsychological testing. And finally, you might remember from the first slide, we also see that there's a need in the comfort area, especially if you know that standard MS protocols take longer than average, and also patients have to be scanned for follow-up, sometimes even up to a couple times per year. And as already touched upon sooner, as I said, patients often have to come back multiple times. And that also means that they spend quite some time in a magnet. And therefore, you really want to make sure that you provide them a good and the smoothest possible experience. And therefore, it's actually good to know that there are the comfort matrices available, making sure that the actual experience is as good as possible, but also the smart workflow solution, which really plays a key role here in speeding up the entire process. And additionally, also the inboard connect and the ambient experience can be very useful here to implement while scanning MS patients to provide them a better comfort during the actual scan. It provides a good source of information to patients on what to expect during the scan session, to feel more at ease, and also to really reduce the risk of rescans, especially as those patients already undergo many scan sessions. This is something you really would like to avoid. And with that, I actually would like to conclude with this summary slide, highlighting again the different solutions already available. And for us, this is actually just the beginning, and we will be working on further improving and expanding the solutions in the MS space and beyond. So please stay tuned for more to follow in the future. And with that, I would actually like to, we come to an end of this part of the webinar, and I would really like to thank you all for your attention. And with that, we will now go back to Dr. Traboulsee to answer some of the audience questions.
Thank you so much, Nadine. I really appreciate that. Thank you, Dr. Traboulsee. We are up against it, unfortunately. So we're just going to dive right in. We have a ton of questions that are coming through here. So if it's okay, Dr. Traboulsee, I'm just going to go ahead and get started. I think you might be on mute. Can't quite hear you. Still can't hear you. All right, we're going to see if we can get that fixed, Nadine, and we're going to go ahead and start with some of the questions we have posed directed towards you, if that's all right.
Sure, sure.
Great. So someone had asked, what is the approach at Philips on activating this collaboration as discussed in your presentation?
Well, it's actually, I think, a very good question. If you look at us within Philips, I think we have a very good network with our neurologist customers, also neuroscience partners and customers, but also with the clinical scientists who really support those. We have a very broad network of clinical scientists really working in the market, is very closely connected with our customers. And that really assures that we really know what the challenges are that our customers are facing, and also how we can directly support that and approach it. So I think that really helps in building strong collaborations with our customers.
Perfect. And I'm gonna try to go back to Tony. Tony, how can we hear you now? No, I don't think we can.
Fortunately not. No.
Maybe if you try logging out and logging back into the meeting, that might help. But in the meantime, let me go ahead and
yes.
Let's try now.
Oh,
yes.
now we've got you.
There you are.
Fantastic.
Well, apparently my technology for sound wasn't great during the talk either. So my apologies to everyone for that. And I'm live now.
The presentation was fantastic. The sound, everything looked great. So, all right. So we've got our first question for you, if that's all right. Was asked, can you elaborate on the standardized protocols? Are the details published? What is the value of this? And what is the role of vendors of this, in your opinion?
Wow, great. Great news. We just heard from Lancet Neurology that the protocol has been accepted for publication. So it should be coming out any day now. And this is the combination international protocol with Magnum's the European group, Consortium of MS Centers and NAMES in North America. So
That's great news.
That's
Yeah,
great
yeah.
news.
Yes.
And what was really neat with this one is the vendors were very involved in the discussion of the practicality of the protocol, with the hope that working with the vendors such as Philips, we might be able to see this more accessible on the scanners. It's really, as I showed you, so like an 18-minute protocol without contrast, which should be very practical for people to use. And it opens the door to doing more with the data. We're just using the tip of the iceberg with just looking at lesions. There's so much more we can get out of MRI. And by being a short protocol allows you to do potentially the looking for the central vein sign, but do discuss it with your radiologist because it's a lot of work. And that might be where artificial intelligence, machine learning, I think where some of the power with that will be in taking large data, even on a single image. If you have a lot of lesions, it's tiring for our eyes to look at it. But if artificial intelligence could be trained, and that's what it involves, to process that data more quickly, I think we still want to look at it too, kind of that, like, when you're driving your Tesla, if you have it on auto mode, you're still going to be looking at the road, I hope, and not playing with your Game Boy. So I think even with AI and radiology, we still need to look at it with our eyes too, just to make sure we're happy with the direction it's going and not crashing into a wall.
Tony, that's so funny. I haven't heard the term Game Boy in a few years now. So thank you.
Showing my age.
So that kind of loops into someone's question on AI specifically, and I guess it goes back into, it's like a CRM or anything else. It's only as effective as the data that you put in, right? And we had a question that you sort of answered already, but I did want to put it out there in regards to AI. It was asking. Essentially, I'm trying to find it here on the list. We had so many questions, but it was, do you think artificial intelligence can play a role in early detection and monitoring? And
yeah, I think it really could, and we've been playing it a little bit with it ourselves. Just looking at using AI, some work by Roger Tam, who's a computing scientist here, looking at AI of conventional imaging plus some advanced imaging, the myelin imaging, to distinguish two similar diseases that look radiologically similar, so multiple sclerosis and neuromyelitis optica. And using AI was really accurate at distinguishing the two diseases. Now, currently, of course, myelin imaging isn't standard imaging protocol in clinical practice, but I think it just shows you the potential. And so where I really see AI in helping with diagnostic process is maybe with the central vein sign. That's more likely to make it into the clinical MRI faster than other techniques. Where I'd love to see AI go with clinical care maybe is helping us prognosticate. So we're really, in contrast to cancer care, where there's different models to prognosticate patients and that helps guide you what treatment you might offer patients. In multiple sclerosis, we don't do a great job prognosticating. That might have implications in terms of how aggressively you treat the disease day one. And so I think that's a potential role for AI. Could it help us with our prognostic models, as incomplete as they are? And so that's one of my dreams.
Oh, that's fantastic. We're going to do a quick pivot here. Questions just came in. How do you define juxtacortical lesions in terms of distance from cortex and shape? Is there any guideline available or in preparation to provide written guidance to that question?
Yeah, thanks, Jens, for that question. And there is a beautiful paper by Massimo Filippi. It came out in Brain about a year or two ago, Brain 2019. If anybody wants to reference, go to the Q&A section. In the answered section, I put the reference there. And so juxtacortical should be touching the cortex. The lesion should be touching the cortex. It should be about at least 3 millimeters in size, ideally. Likewise, periventricular, it should be touching the ventricle. And that decreases the false positives of the non-specific white matter lesions. again, people without MS can still have these lesions. They're more common in MS. And so applying these criteria to the appropriate patient is still critically important.
One other question we have for you, Tony, and then I'm going to come over to you, Nadine, if that's all right. fMRI important for MS, and is it replace T1W content? Not exactly sure on that question. You might be able to understand that a little bit better than I can.
Yeah, no, that's great. There was a couple of questions around resting state fMRI or fMRI and its potential clinical role. I don't see it yet as a clinical tool. Bear in mind, I'm not an fMRI expert, so I might get a lot of hate email later, but I think it's a beautiful research tool but to translate it into clinical practice, I think we need a better sense of what is its clinical value. Does it truly tell us if a patient is failing therapy? Could it give us prognostic value? I don't see it improving diagnostic value, but where I really see it expanding more maybe is in clinical trials. We're looking at new therapies that might promote remyelination or also improve neuronal connectivity. And so it's possible where we might not be seeing structural improvement on an MRI. With remyelination we can, but let's say it's more connectivity. We might need a tool such as resting state fMRI in combination with cognitive testing to demonstrate value of new therapies. And the whole idea of using MRI in clinical trials is to try to get an answer more efficiently so that patients aren't being exposed to an experimental medication for a long, long period of time to see the clinical impact. We want to know if we're going in the right direction with minimal impact and exposure to new patients.
Okay, Tony, don't go anywhere because we're going to be coming right back to you. Nadine, this one's for you, if that's all right. Where do you see the biggest opportunity when pushing for new clinical boundaries?
Oh, that's actually a very nice question. That would really be the direction of, as I would call it, the solutions approach, meaning that to really make steps here, we should really look at the entire patient pathway and really looking what are the specific needs for a patient group, like we are discussing now for multiple sclerosis today. But you could also, of course, look in other neurological disorders such as stroke, but also Alzheimer's disease, or even psychiatric the pathway that a patient goes through, what are actually the main possible prevention, the diagnosis, treatment selection, the actual treatment, but also follow-up and even the home monitoring of patient, because it doesn't stop when a patient leaves the hospital. I think I just dropped off for a few seconds because my internet connection was a bit unstable, I guess. But at least we want to really look at the entire care pathway within specific disorders and try to address all these needs in that pathway, and not just only look at one single modality, just looking at what MR could do within MS, but really looking into the entire continuum. And I think by doing that, I think that's really the opportunity and doing that allows also creating much more impact for the customers, but also, of course, for the physicians and professionals in healthcare.
So, and we just have so many questions, but we're unfortunately up against it. So we only have time for one more. And I wanted to let everyone know that if you have any questions that haven't been answered, we're going to make sure that we get them over to Dr. Traboulsee and to Nadine both, so that they can answer your questions. And anything that you might think about after the fact, please email us at webinars@antmini.com. I'll make sure I get them to Dr. Traboulsee and to Nadine both. And we'll be forwarding the questions in from today's presentation to both of them as well. And as a reminder, we're going to be sending a follow-up email tomorrow to all registrants and to all attendees with a link to this presentation, including the Q&A portion of this. So one last question, Tony, if that's all right.
Yes, absolutely.
You showed how SDMT performance correlated well with myelin water imaging. How could such finding be incorporated into the clinical workflow?
Yeah, I think initially what I see being valued in the clinical workflow is getting more cognitive tests on our patients. We really don't do that in clinical practice, and that's why I was really keen on Nadine's presentation. And even SDMT is such a simple tool. It doesn't capture all the aspects of cognition, but at a minimum, it'd be nice if we could capture that once a year, and then we can track what's happening in terms of our patient stability clinically until we can get more imaging tools such as myelin imaging on all your scanners to provide that quantitative data. So, but yeah, no, I think I would love to see more cognitive outcomes performed on our patients in routine practice, and the reproducibility is excellent with those tools, and I think they're value added without too much burden on the clinicians.
I could
Well,
only agree with the last answer you gave, Tony.
Thank you.
yeah, so first of all, I want to thank both of you. We've just slightly gone over the hour, which is okay. But I want to thank everyone who was here that enjoyed the presentation. Again, if you have any questions, please send them to webinars@antmini.com. Dr. Traboulsee, Nadine, thank you both so much for your time. And I'd like to have a special thanks to the Philips team for sponsoring this content today. It was great. Again, this is something that's very personal to me on my side. So thank you guys very, very much. Wish we had more time, but looking forward to seeing everyone in the next installment in the Philips webinar. And have a great day, great morning, great evening, wherever you are. And thanks again.
Thanks, everyone.
Thank you. Bye-bye.